Hi, everybody. Welcome back to episode 4 of the Author Podcast. This week's podcast is focused on medical errors. Pretty much an entire episode of my opening rant, but we'll end with a promo of one of my favorite books I wrote. Now, let's go. So I just came off a string of shifts in the ER, right in the heart of flu season. So sorry for the congestion and altered voice, but it is what it is. So here we go. Watching the news of the tragic airline accident in DC prompted me to move this topic up the list of ideas for the podcast. It's something I've wanted to do for a while, and it's very frustrating, especially what happens in the news. So here we go. The airline industry has made incredible improvements in safety over the years. There's multi-layer processes and cross-checks in place to stop crashes and other tragedies from happening. Despite all of that, things still get through, as we just saw. Now, this discussion of the Swiss cheese effect, where you have multiple layers that have slight defects and holes in the processes that could lead to harm if the holes line up, right? And you can slip right through without hitting one of the walls. And then you end up with a tragedy like we saw in DC. So the hope is that the multi-layered approach creates a block where the holes don't line up and the next layer stops the air from progressing to an endpoint. So consider firearm safety. If you're not aware, there's 4 rules for gun safety. Here they go. Treat all guns as if they're loaded. Know your target and what's beyond it. Never point the muzzle at anything you're not willing to shoot. And keep your finger out of the trigger guard until you're ready to shoot. So in order to have a problem, you need to violate 2 of the rules if someone's going to get hurt. Now, you could point a gun at someone, but if your finger's not in the trigger guard and off the trigger, it's not going to fire. If you accidentally pull the trigger, but it's not pointed at anyone, no one will be harmed. So this is a small stack of Swiss cheese, only 4 layers, but it only takes 2 rules to be broken for something to happen. So obviously, despite everyone's best intention and multi-layered safety protocols, bad things can still happen. So over 60 people lost their lives this weekend, and soon we'll know the full details of what happened. But leaders in medicine have looked at the airline industry as the industry to model our safety approach after. They have an incredible amount of customers served in the airline industry with excellent track records for safety. And we want that in healthcare as well. We don't want people harmed. But for context, there was a ridiculous study that came out a few years ago that suggested medical errors were the 3rd leading cause of death in this country. Absolute insanity. But they defined a medical error as a result that was not the intended outcome. That's ludicrous. That's not the definition of an error. But what the concept does is it disincentivizes doctors from performing risky procedures. Our modern culture publishes complication rates and outcomes on surgeons and procedure lists, and hospitals for that matter. So who would you rather take to the cath lab if you're a cardiologist? A 40-year-old healthy guy who has chest pain when he exercises? Or a 95-year-old person who was found down at home and had 15 minutes of CPR with evidence of an acute heart attack on EKG? Which one of those 2 is more likely to die in the immediate post-op period, if not on the table? So one could argue this is a do-no-harm situation, right? But consider an orthopedist seeing a patient for right knee pain. The patient is 100 pounds over ideal body weight, they smoke, and has severe arthritis in the knee. The surgery is likely to have a difficult recovery phase, potential wound issues, and potential need for revision if any of those complications happen. All of those will be reported in the surgeon's statistics. And no surgeon's required to perform an elective surgery. It's up to them if they do it. So the patient could be in severe, excruciating pain every day and still not receive surgery because of the risk of complications. Now, this is why patients are counseled to quit smoking and lose weight prior to elective orthopedic surgery, both for the benefit of the patient in their postoperative outcome and for the state of the surgeon. If patients wanted to take the risk and the surgeon wouldn't be penalized for the disclosed and anticipated complications, they would be much more likely to receive surgery. So let's look at categories of medical error. Now, this list is in no way comprehensive, but it's a good start to the discussion. And this list comes courtesy of the Agency for Healthcare Research and Quality. There's communication errors, inadequate information flow, human problems, patient-related issues, organizational knowledge, staffing patterns and workflow, technical failures, and inadequate policies. All of those can lead to problems. So ideally, there would be this multi-layered safety protocol for each of the categories, but that's a lot, right? So let's take a look at communication errors. Let's say a nurse tells me my first dose of pain medication was inadequate for my patient who's here for a kidney stone. So I'm walking down the hallway, she stops me, says, "Hey, this guy's still in pain." I said, "All right, go ahead and give him 1 milligram of Dilaudid." I'm not in front of the computer and system, I'm in the hallway. She hears my order, goes back and enters it. Now, what should have happened is that she repeats my verbal order out loud back to me to confirm that she understood me correctly, and I listen to her repeat it and confirm that indeed was my order. Then she goes immediately and enters it. Now, in our modern electronic health record system, now that order will be checked against the patient's allergy list Usually a pharmacist will review their order in real time, or 30 minutes later as it seems when you're in a rush, and ensure that it's the appropriate medication with no significant medication interactions, and then the nurse pulls it from the medication dispensing machine once it's approved. Now, hospitals have put red squares on the ground around the machine, indicating we should not talk to people in the red square as they pull the meds to reduce the risk of errors. It makes sense, right? But the funny thing is there's no red box around me, who's actually the person ordering the medication. I get interrupted constantly while entering orders, and this can lead to the wrong orders or selecting the wrong patient as we try to multitask our massive patient load. But this shows the multi-layered approach to safety with medication order. When the nurse goes to the room to administer the medicine, she'll scan it with the barcode scanner so the health record confirms what's on the vial, confirms it's the correct medication. Once they confirm it's the correct patient, they then receive the medication. Perfect, right? But what if she entered the order on the wrong patient based on my order? Or what if I did? What if the triage nurse didn't document the allotted allergy? What if the patient forgot to tell us about it? What if the patient's blood pressure dropped in the meantime and the dose of narcotic is no longer appropriate? So despite so many layers of safety, it's a fluid situation and problems can still arise. Now, anesthesia has set up incredibly robust protocols for safety, and that's why surgeries in the United States have a very low anesthesia-related complication rate. It's impressive. So while that's great for them and the patients, the House of Medicine then looks at the emergency department and other areas, saying, why can't we perform just as well as anesthesia? They point to the airline industry and wonder, why can't we do the same? So generally speaking, anesthesia knows what cases are coming. The patients are pre-screened. They've had several physicians evaluate them both in the outpatient and inpatient setting prior to showing up in the operating room. The patient had preoperative screening tests done to ensure the lowest possible risk. Their medications have been adjusted for the same reason. So if something is off with any of that, or with the patient, or the physician, the case is canceled and rescheduled at a later time. Wouldn't that be awesome? How do I do that in the emergency department? How do I just say, not right now, we'll get to that later, maybe in a week? So we have people that come straight from the buffet at the casino with a dislocated hip. They're on blood thinners, they're on oxygen, they have a full stomach, and they're from a different state, giving us no access to their prior health records. I would love to be able to have the benefits of scheduled cases to prepare for my procedure. So we do our absolute best and check what we can and really do a pretty good job in the grand scheme of things. Now let's look at it again from the commercial airline industry and compare to what we do in healthcare. So we have significant staffing issues in the hospital and office-based systems now. There's no minimum number of staff that must be present in order for patient care to occur, at least in the emergency department. So we don't schedule patient visits. I wish we could. Some actually do, but that's part of it. That's not all of it. So you can still just walk in. Now, it doesn't matter how many staff there are in a given shift in the department. An unlimited number of patients can arrive, needing unlimited testing and resources. And when it overwhelms the system, administration gets mad and tells us we need to work faster, work harder. Here's some pizza. So if we operated like a commercial airline, we would have twice the number of physicians, nurses, and ancillary staff that we need, just in case something happened to one of them, or if one of the doctors got tired and needed a break, right? Pilots, co-pilots, navigators, they have backup systems and redundancy to be safe. We would have all of our patient encounters scheduled weeks and months in advance. We would make sure that the people who come to the hospital are properly screened and do not pose a risk to anyone. We would make sure that any agitated or violent patient gets immediately removed and banned from ever coming back. We would limit the number of hours people could work and simply cancel cases if the doctors or nurses work too many hours in a row. Oh, sorry, we didn't get your case started in time. We'll do it later. So if the weather is bad or some of our equipment doesn't work, we just shut down, not see patients. When the department got busy, we could double our fees due to the supply and demand curve the rest of the economy is allowed to use. Now let's say someone decided to come to the hospital. They made their appointment, but at the last minute they didn't come. We could still bill them. This would dramatically help increase our staffing with this extra revenue and surge pricing, and still billing people full price who canceled their visit. And also, airlines know where they're starting and where they're ending. We don't. They know the best way to get there and everything else going around them. The airlines prepare the right-sized plane for the distance they're going and the number of people who want to go there. They divert around storms. They get in a holding pattern if the runway's full. In medicine, we often have no idea where we're even starting. Somebody just shows up, can't talk to us, they're unresponsive. And it's unclear if we can get to where we want to be, how many people are joining us, how much help we have, and how many other people are going to be there directing our attention also. So as a general statement, of course we want to be as safe as we possibly can be. We want to ensure good outcomes for patients and limit any potential harms. But there's massive differences between healthcare and the airline industry, and there always will be. So I hope this helped bring attention to some of the struggles that we have in the healthcare industry and why it is so hard to avoid any possible error. So know that when significant errors do happen, they're nearly universally accidental. They're not intentional acts, right? And we feel awful for the patient, regardless of whether we are involved in the chain of events. We feel bad for the patient and the people involved. Even if it wasn't our fault, we remember these errors for years to come, and hopefully will help stop it the next time. Moving into the final segment this week, let's dive into my psychological romance drama novel, It Happened in the Loft. So I had a few reasons to write this book. One, I wanted to write about PTSD and the new therapy that's coming online, EMDR. It stands for Eye Movement Desensitization and Reprocessing. It's a fascinating concept where the therapist attempts to rewire the brain in the area where the traumatic event is stored. So basically, to reduce triggering moments and help process the prior trauma. It's a similar concept using ketamine or psychedelics to aid in the therapy of events that led to PTSD or depression. So in this novel, my main character, Dr. Alex Lee, is an ER doctor who had something happen when he was young. He grew up in Indiana and where a tragedy occurred in the family barn. He's haunted by that memory, and it shaped who he and the rest of his family is today. Unfortunately, that leads to difficulties treating patients, interacting with others, and having successful romantic relationships. He understands the problem, but not how to deal with it. So it takes a budding relationship with the nurse to convince him that it's time to take a serious look at getting help. If he's going to have a relationship with her, he needs to fix himself first. And trust me, there's a lot of truth in our own lives in that statement. Now, this novel follows him through his therapy, and through flashback moments, it tells the story of what happened in the loft. His girlfriend, the nurse, has her own issues that they work through, both medically and emotionally. And it leads to what I feel is my best ending of any novel, at least until I wrote Sacrificial Touch, but that involves miracles in heaven, which is a bit of an unfair advantage. So I wrote this novel to be a bit of a psychological thriller, but it came out more of a psychological drama with more romance than I intended. Now don't get me wrong, this is not spicy romance, it's quite clean. You should enjoy this story and have a big smile on your face, if not a tear in your eye, when you close the book. So the most recent review on Amazon reads as follows. I love reading novels that have medical issues in the story. To be paired with a very cute romantic twist was a bonus. I loved how the couple had great respect for each other. It is refreshing in today's world to read a love story as such. Thank you for a joyful read. You are absolutely welcome. So find my book on Amazon in paperback and ebook. It's also available in Kindle Unlimited. That brings us to the end of this episode, and as you can see, I did adjust my desk a little bit, but I didn't like the full 90-degree rotation. I really have about an 8x8 space to work with here, and there's only so many options to set this up. So I didn't get to do the on-location shoot this week, but I promise you it's coming, as is the interview with my friend Dr. Dee Bonnie, discussing ketamine, psychedelics, and other therapies for PTSD, anxiety, and depression. So it's almost February, the weather's warming up, our snow's melting. Now let's go enjoy this beautiful gift of life.